So hi guys, you guys welcome. We are going to get started. So I would just tell you a little bit. Most of you know me or know something about me or on social media. So I'll give you a little bit about myself. I am a cardiologist by training, which is sort of interesting. How did you get into this space? I transitioned over into research, worked at Abbott and Solvay for many years, really in hardcore R&D, research and development. And then went on later to lead a large research site at the Piedmont Healthcare System, and then to develop their innovation program. And then COVID hit, right? And I was asked to lead this temporary effort on COVID. It was going to be 4 to 6 months. We were all going to shelter in place, and then Dr. Jane Morgan could go right back over to her research. And so here we are 2 years later. And so this has really become quite a bit of a passion of mine because it has integrated so much into health equity and what I'm seeing in Black and Brown communities and all of the things that it has awakened. And so I've started the Stairwell Chronicles really just to be a point of information and to demystify science and to sort of cut through all of the noise. And I'm being careful not to say nonsense. So I'm just going to call it noise that you see all over social media, and to make certain that you can have a really straightforward voice of science and reason that is apolitical. So that being said, this is called Stairwell Chronicles Live. I do something called Stairwell Chronicles where I sit on these exact steps and I speak about one particular issue with COVID in 60 seconds or less. Haven't done it in a while, but I probably did over 100 or so of those in the last 18 months. And people follow along and learn about COVID, the vaccines, their neighborhoods, that sort of thing. And so that's what we're doing. So today I really want to talk about where we are in this pandemic because it seems confusing. Everyone has been told to take off their mask, and we're all sort of freely filtering around and integrating with one another. But is that really the best course, and why are we doing that? So I want to start with this concept called herd immunity. It's probably something that you remember that we used to talk about. So herd immunity is when enough people in an environment develop an immunity to a disease, then everybody doesn't have to have the immunity. As long as the herd, the people surrounding those people are immune and have some degree of immunity, the virus or the infectious agent, the bacteria can find, a parasite can find no portal of entry. And so that number generally is pretty high. Around 80 or 85% of our entire population needs to be protected against any type of infectious agent, such that the other 10 or 15% can continue to live healthy lives even though they've never been infected and have never been vaccinated. That's called herd immunity. It literally comes from farmers at the turn of the century, not the turn of the 20th century or the 21st century. I'm talking about the turn of the 19th century. Farmers noted that when their herds, cows, cattle, actually became infected, those that lived, that survived the disease process seemed to go on to have long-lasting immunity, and calves that were subsequently born to that herd and those that were subsequently purchased to fill out the herd also seemed to not get sick. That's called herd immunity. That's why when people say, I never get vaccinated, my parents never get vaccinated, we all stay so healthy. Well, the reason you stay healthy is because I got my vaccination and I live next door. And somebody across the street is vaccinated and all the people at your school are vaccinated. So you're really healthy because the herd is healthy. And so by being espousing your superior health, and maybe you've achieved some specific level of health nirvana, in actuality, you are not independent in your health if you have refused vaccinations. You are actually dependent, and you are dependent on me and people like me who get our vaccines. That's how you stay healthy, not because you've developed any special type of evolutionary process or you found exactly the right cocktail of vitamins to take. That's the concept of herd immunity. It blunts the effect of the disease process in our community. And so what I'm going to tell you now may or may not be a surprise, but it is unclear to me. In fact, probably not possible any longer for us to achieve herd immunity here in the United States and maybe not even around the world. And here's why. Every single opportunity that we have had where a door was opened or a window was open, we have allowed it to shut. When we were supposed to wear masks, when we were supposed to follow public health measures, when we were supposed to isolate, when we were supposed to step up and get vaccines, we really have stumbled through these things and never really as a society stepped up to do anything collectively. In fact, that's what public health is. It's the collective effort of a community to move forward in a specific direction. And certainly here in the United States, we have never seen that collective will. In fact, we have seen the destruction and the attempt at destruction of that collective will. And so what has happened is that it has completely dissembled and dismantled our ability to achieve herd immunity. So why do I say that? At this point, 2 years into it, thousands of mutations later. Remember, we're talking about herd immunity 2 years ago when we just had early mutations. We are thousands and thousands and thousands of mutations later. When we look at all of the sublineages of Omicron, so BA1 is the one that everybody knows about and gave us this big surge, but then we had BA2, BA4, BA5, BA2121. Why are all of these important? Because all of them, the last 4, did something very evolutionarily suspect and concerning. And that is that they all arose virtually simultaneously in 4 different regions of the world: South Africa, the United States, France, and Belgium. They all had the exact same mutation, this L452 mutation, and they all were able to evade our medical therapeutics and partially evade our vaccines. In fact, these most recent sublineages of this entire Omicron family have now rendered all of our monoclonal antibody therapies useless. And so we can no longer reach herd immunity, because part of reaching herd immunity is you can have the ability to have long-lasting immunity. And now we know we can't do that with these new variants. They can reinfect and reinfect you and reinfect you. So we know that we won't be able to achieve that. We also know that we have asymptomatic transmission, which is also difficult to achieve if you're trying to work towards herd immunity. So I want us to think about that as I continue to talk for the rest of this half an hour, to say we really will not be able to achieve herd immunity. So what does all of this mean as we put it all together in its Darwinian concept, Darwinian evolution, and the very specific and conscripted development now of these variants? They are evolving in a very specific way and in a very specific pattern. So again, if we want to talk about Omicron, one of the things that we know about Omicron, when I talk about Omicron, what I'm mentioning here, I'm really talking about all 5 of the sublineages. So when I say Omicron, I'm talking about all 5 sublineages. This particular sublineage development, although Delta has sublineages and also Beta, these sublineages have been significant. And generally we don't see them of significance in that they can evade all of our wonderful scientific developments. One of the things that has been concerning to myself and other scientists and others in the medical community is that the political theater of let's all move forward, we're done with this virus, let's all remove our masks. This particular variant is not that serious because it doesn't cause very serious disease for the most part, unless you have medical conditions or unless you're immunocompromised. All of those things are true and yet very short-sighted. That's not long-term thinking. That's not the thinking of a CEO. What am I talking about? If you are moving around freely, let's say you didn't get vaccinated or your vaccines are old and you didn't get a booster, and you get infected with one of these Omicron variants, you probably will be pretty healthy. You'll be fine. You may have some cold symptoms, allergy symptoms, maybe something more severe that seems more similar to the flu. But by and large, you'll stay out of the hospital. And definitely you'll stay out of the morgue unless you've got something else going on. And so people have become very cavalier about that. But what does that mean? That means literally these variants are infecting millions of people. And what does that mean? Every time one of these variants, this virus invades your body, it does what? It replicates, and then it has the ability to mutate. And what do these mutations do? These mutations cluster together to give us these variants. Variants are clusters of mutations. So in being casual and cavalier and unconcerned about whether we get infected or not, we actually are endangering what could happen in the future. The present is nice. Okay, we can live through this, but this is not endemic. This is not what endemic means. Endemic means that it is at a very low level. That is not what we're seeing here. In fact, the United States is on fire with COVID. We have a map that is shaded red, which means high and substantial. And these are just the cases that we are counting. There are 5 to 10-fold more cases that go uncounted because home health tests, home COVID tests, right? We don't report those. And then just a number of people who simply have symptoms and they don't test at all. And they don't isolate and they don't report it. And I think they probably do think that they have COVID and they don't really bother with it. And they go out and continue to infect others in this whole maskless environment. And so you can see where I'm going with this. Just round and round and round and round and round we go. And even though we have this family of sublineages in this Omicron variant that don't seem to provide very severe disease or severe illness or sickness, the risk of that is you get lulled into a false sense of security that could threaten your life and those of your children and others down the road with a more serious variant. All of these infections give us the opportunity to develop another variant, and these particular variants develop the exact same mutations in 4 different regions of the world simultaneously. We have not seen that. So this virus is evolving in a very consequential way and intentional, very different from what we've seen. What we can say about our vaccines, however, is despite the formulation not changing through these last year and a half that we've had vaccines available, the vaccines have continued to hold up very well against the Greek alphabet. And we continue to be happy with that. In fact, if you get your booster, you're back up to 95%. The problem that we struggle with these new variants is that there is not durability of our vaccines. In other words, once you get vaccinated, it's not long lasting. It is not durable. These new variants can evade some of that efficacy, some of that effectiveness. And so we need to get a second booster or a third booster. I don't know how many are coming down the pipe in about 4 to 7 months. That's because that's when we see our vaccine, those neutralizing antibodies start to wane. They start to drop. And so they go from 95% to 90 to 85 to 80 to 75. They start to taper over the few months. At 4 months is really when they start to drop. And then research has shown us that 7 months after your last shot is really the ideal time to get your next booster, because that is when you get the most antibody reaction. So the problem with that, I'm not saying get it or not get it, just giving you the pros and the cons. The problem with waiting 7 months is you got this gap of 4 to 7 months, right? 4 to 7 months after you received your last vaccine, where your levels are dropping and you're less and less and less protected. And that's why we say that's a good time to get your vaccine. But research has also shown us that if you can wait to that 7-month mark, you get the biggest boost in your antibodies, but it also leaves you, right, more vulnerable in that 3-month gap. So those are things to weigh and balance. The other thing that I want to talk with you about, because so many people have been infected, is if you have been infected with COVID, and let me talk about the different variants. Let me just say if the Delta variant, and maybe you don't know which variant, so let's talk about time frames. So let's say if you were infected with COVID in 2021, let's talk about all the variants in 2021, then you absolutely do not have any protection against Omicron and its sublineages. All of these sublineages will reinfect you if you are infected with Alpha, Beta, or Delta. Those are all of the ones from 2021 and 2020. So you absolutely do not have coverage for that. You should not feel confident to say, oh, I had COVID last year, so I'm going to be protected. That's absolutely not true. And that's exactly what I'm saying about this particular family of the coronavirus, or SARS-CoV-2 family, severe acute respiratory syndrome coronavirus 2. What I'm saying about them is that they have the ability to reinfect, so you do not have long-lasting immunity with the previous variants. If you were lucky or unlucky to get infected with this particular wave, so say the end of March or April or May, you probably were infected with one of the Omicron variants, and you have some protection against this particular wave. And so if you've been infected, you probably can wait 30 to 90 days to get your booster if you're trying to time it. We are expecting the summer to be okay, although we see it really burning through and then having somewhat of a surge in the fall. So let me talk about the CDC and the CDC maps for a second, because the CDC I thought was somewhat disingenuous, and if anybody follows me on Twitter, I've been pretty vocal about it. But they changed their map from a map that used the yellow, red, and blue to sort of a map that suddenly was all green. And that green looks very calming and peaceful, and look, everything is fine. But what they did was the previous map that was yellow, blue, and red actually depicted the transmission levels of COVID in the environment. And those levels were determined as being low, medium, high, or substantial. What they did is basically those numbers were based on a population of 100,000. And once you got beyond a population of 100,000, they call that really above, high, and substantial. They created a new map, and the highest that you could get on the previous map was 100,000 population. They created a new map, and the lowest was 200,000. So the lowest number on the new map was twice what the highest number was on the old map. And that's why I called foul and said it was gaslighting and moving the goalposts, disingenuous, and puts us into a false sense of security. And so suddenly, literally overnight, and I do mean overnight, one day the map was shaded in red and yellow and blue, and the next day the map was all green, the exact same map, the exact same communities, because they literally changed the definition. The case numbers didn't change. They simply changed the definition. And so that's what you've heard scientists, myself, I've been on different programs talking about it, but others have sort of cried foul, because what we're concerned about is that what do doctors practice? Doctors practice preventive care. The best doctors do. We work to prevent disease. That's why we schedule mammograms and colonoscopies and check your blood pressure. We don't wait until you get sick, ideally, and then intervene. And so this is how public health should be practiced as well. And certainly this COVID pandemic, where there have been a lot of missteps. And so with this new green map, The goal was to wait until hospitals started to fill up with patients and then to sound the alarm. And from my perspective and other perspectives of other scientists and clinicians, that's too late. You don't wait until the horse is out of the gate before you sound the alarm. We need to know on the ground when something is happening such that people can start to make decisions about how they're going to live their lives. And so that's where we are. I want to spend some time talking about Paxlovid because so many people I have heard tell me that, this particular variant is not that serious, and even if I do get sick, I'll get Paxlovid, which is an antiviral, anti-COVID agent, and I'll be fine. So, okay. Let's talk about that for a minute. So, Paxlovid, made by Pfizer, right? It is what we call a protease inhibitor. So, protease is an enzyme that is required for the virus to replicate. In other words, to make copies of itself. So they've developed a drug, Paxlovid, that inhibits that enzyme, that catalytic process, so that the virus can no longer replicate and make copies of itself. So it is a protease inhibitor. That's what Paxlovid does. It uses a booster called ritonavir, which is a type of antiviral that actually is used in HIV patients to increase its efficacy. So that's Paxlovid. Paxlovid is hard to source. It's not really available everywhere. 2, you really have to start it within 1 to 5 days of onset of your symptoms. And so the other thing that we absolutely want to talk about with Paxlovid is even if you get it, you must take multiple pills a day. It's not one pill for 5 days. So it's a 5-day regimen. It's not one pill for 5 days. It's a multitude of pills for 5 days. So in this case, it's 2 pills plus the 1 ritonavir, and you take them twice a day. So that's 6 pills a day, and you'll take them for 5 days. So you really will take a handful of pills. You'll have to take 30 pills over that course of 5 days. That is not innocuous. Why are you going to put yourself through that when you actually could have just gotten vaccinated and maybe worn a face mask? Now you got to source Paxlovid. Hope you can find it. Hope you can get it started within the first 5 days of your symptoms, and then gobble down 30 pills. And then what we're hearing now, and I have 1 case in the literature that I looked up, that we only have 1 case so far, but people are talking about it, is this Paxlovid rebound. So you can actually take Paxlovid, complete the entire 5-day course, feel better. Most people feel better within 2 or 3 days. And then around day 9, 10, or 11, you start to feel sick again, and you go back and develop your COVID symptoms, maybe even worse. We call that Paxlovid rebound. In the clinical trials, 1 to 2% of people in those clinical trials also experience Paxlovid rebound. What does that mean? It probably means that a 5-day course of Paxlovid, all 30 of those pills, may not be enough for some people to really clear that virus. And so after you complete those 5 days, you still have some viral titers, some viral levels there. And so once that medication is out of your system, what happens? The virus just starts to go back up and you get sick again. So you say to yourself, okay, well, maybe that's a problem for the doctor to think about, but I'm not going to die. Well, so, okay, I take all the pills, I get better, then I don't get better, I'm sick again, then I get better again. So, okay, I'll take a few days off from work. But first of all, that's, insane to live your life that way, right? Why do you want to live your life that way? And 2, here's something to think about beyond the insanity. It can increase the risk in society of developing resistance to the drugs. If you allow the virus to be exposed to the drug and you don't eradicate it and get rid of it, it now learns while it's on board with the drug and then has a chance to rebound once you stop the drug. That's how you develop drug resistance. And we don't want to be, we have so many drugs that are resistant, especially our antibiotics that we try to use judiciously because the bacteria have gotten so smart. That's exactly what happens if you have a cavalier attitude about Paxlovid rebound. So what? I'm not going to die. I'll just take days off from work. First I'm sick, then I'm not sick, then I'll get sick again. I took 30 pills. I don't know. Seems okay to me. I find that to be insane. But maybe that's okay with you. So maybe the other thing to think about is not just yourself, other people who might need Paxlovid, and because of your cavalier behavior, that resistance has started to develop. A resistant virus to Paxlovid, which is one of the only antivirals that we have to try to help control the symptoms. It's not a cure. We still yet do not have a cure for COVID. So there are multiple issues going on simultaneously, including I disagree with the Ed Bastian and Delta Airlines, and I don't know where you all are, but I live here in Atlanta and I'm proud of Delta. Delta is headquartered here, but Delta Airlines should not be leading public health policy. That is not their job. And so for them to contact the CDC and contact the FDA and talk about how it's impacting their airlines, that's not what public health should be. Our job, or the job of physicians, is not to ensure that the economy moves forward. We're supposed to work in a vacuum, really talking about public health. So my suggestion to you is going to be, in this environment of monkey virus and other viruses, as you see, that will continue to develop. And that's another story about our pandemic, our global pandemic surveillance team that was dismantled under the previous administration. We never know when you're going to have an outbreak, and we must be prepared globally. The World Health Organization, the CDC, we must all work together. You have to have a system we have called an HAN system that begins to alert physicians. We get the alerts on our phones, on our watches, of new viruses that are coming in and what those therapies are going to be, and if we have no therapy and what precautions have to take place. Most doctors have never heard of monkey virus. You may not know that, but most doctors have not heard of monkey virus. And I'll tell you why. In our medical school curriculum, there is so much to learn until exotic infectious disease agents are generally an ancillary chapter at the end of the book. And it's not going to be on the test. You can read it if you want to and you have time. Or if you happen to be going into that type of specialty of infectious diseases. But for the most part, doctors don't know about monkey virus, have never seen a patient, let alone never treated one. Not in the United States. I don't know anybody that's ever treated a case of monkey virus. Like, nobody. And yet, we've got these cases cropping up. And once again, just like COVID, just like me, just like others, we've got to quickly come up to speed, quickly read, and quickly be adaptive in our therapies, trying things. Exactly what has happened with COVID early on. Before we had therapeutics, doctors tried things, steroids, remdesivir, turning patients, trying to drain the lungs. We tried one after the next, after the next, after the next, until therapeutics became available. We would end up having to do this with monkey virus if it becomes a problem. It does not seem to be as transmissible as COVID. But here's something. I gave an interview on monkey virus back in July and August of last year. You may not remember, but we actually had a case of monkey virus here. I gave a couple of interviews on the news about it because it was a person who lived in Texas, who had been in Nigeria, had traveled to Texas through Atlanta, had a layover in Atlanta, gotten onto a second plane and traveled to Texas, where she was subsequently diagnosed with monkey virus. And so they wanted to know, what are the possibilities, as the CDC was scrambling to contact everybody on 2 airlines, plus the airport that she may have walked through, et cetera, et cetera. And do you know, the reason you didn't hear about it, and I did 2 interviews, is that there was not a single case of monkey virus. And she flew on a plane. And you know why? Because at that time, airlines everywhere were requiring masks, and also the airports. So she actually protected, and all the people seated around her were fairly protected. Now, there are other ways to transmit monkey virus other than respirations, but I'm giving you an example of masks are important in a public health emergency where we have an opportunity for respiratory spread of viruses. So think about where you need to wear the mask. I would suggest, I'm living in Georgia. I don't know where you're living. I'm living in Georgia. That map looks pretty red and orange to me. That looks like fire. We are on fire. And don't forget, even those cases are undercounted by 5 to 10-fold.
What?
If I were me, and I am me, and I lived in Georgia, which I happen to do, I'm going to wear a mask everywhere I go, especially indoors, especially if indoors is crowded, or if it's not crowded, but people will be passing me frequently. Put on your mask. That is a minimal barrier to protect yourself, an N95 or a KN95 mask, until we can get to the other side of this. This is not endemic, and our behavior, which has 100% driven this pandemic, this COVID pandemic has been driven 100% by human behavior, not virus, not viral behavior. Human behavior has 100% driven this virus, and it will continue to drive variants until we get one that makes us understand what's really happening. And that's what we're trying to warn against. So look at this map. The CDC finally, Rochelle Walensky, whom I like, and I feel saddened that the CDC appears to be subjected to political subjugation. Let me just say it that way. I feel saddened for that, because we've got to hold ourselves to a higher level and just interpret and provide the science. Let the economists do the economy. I'm not saying that in a cavalier fashion, like I want everybody to die and I want everybody to not eat. I'm just saying, do your job. That's your job. Think about what your job is. Let other people manage their jobs. And so I do feel that there's been some subjugation and politicization. But I was happy to see that just a few days ago, she finally said, well, it looks like 32% of the country is probably in a zone where they need to wear a mask. That was conservative. Remember, we are 5 to 10-fold undercounting. And she has continued now to join, I would say, the ranks of her colleagues, me and others. And I'm certainly not at her level. I'm not the director of the CDC, but I'm just a scientific person giving information. She finally has decided to join us to say, you know, I guess we do need to have on masks. Now, the political theater of the United States is we're not going to have mask mandates. We're not going to reinstitute them. This is not a very serious virus, but I've given you the information for why you need to think long range and not short term. Not this particular series of viruses, sublineages, which, as I've told you, have specifically evolved in a significant and consequential way in an identical mutation in 4 different regions of the world simultaneously. That is what we call Darwinian evolution, if you don't know it and understand it. And it's happening right before our eyes. So understand that you can be lulled into a false sense of calm, but the storm is coming later, again, driven by your behavior, driven by your choices. And so I just want to tell everybody, thank you very much for coming tonight. I appreciate it. And I give you a quick, next month, I am going to be talking about the health of women over 50, specifically menopause, and why we're suffering from bone pain, arthritis, fatigue, weight gain. I'm going to have a specialist on to talk about all of the things that we need to do that we don't hear about in clinical trials, the drugs that we need to take that they don't tell us about. I'm going to tell you about them because she fervently believes that we are all suffering needlessly and there is a way out of it. And clinical trials, which I've also talked about, have given much information on what we should do. And I want to make certain that people of color who suffer more from menopausal symptoms understand what it is. I'm going to also have tons of OBGYNs on here because even the doctors don't know. So we're going to have some fun. It's June 27th. So thank you everybody for coming tonight. I appreciate it. I hope you learned a lot. I think almost everybody on here can reach me. And so either you've got my phone number, you've got my email, or you can hit me up on DM on social media. So if you've got questions or even suggestions for a future one, hit me up. Happy to do it. And I'll talk to you guys soon. Bye.
Thanks, Jen.
Bye.
Great job.
Thank you.
Fantastic.
Wonderful. Wonderful.
Thanks, guys. Hey, Jerry.
I'm asking the call.
Absolutely.
I'm asking the call.